One, we are going to go over the male reproductive physiology. And to get started, let's just go through some basic learning objectives. We'll start with some basic anatomy. We'll tie that together in the end with the endocrine physiology. So we're going to expand upon the introductory hypothalamic pituitary information and then tie that together with the gonadal areas. So now we'll be talking about the HPG axis. We'll go through the male system in this lecture, and then following, there will be a video recorded lecture on the female anatomy HPG system. Okay, so when we think about the goals of the male reproductive system, it is to mature sperm. So those spermatogenic properties are going to lie with cell types in the testes. So there's two specific cell types for endocrine physiology you'll have to know. So we'll talk about Sertoli cells and Leydig cells, know what they produce, and what hormones from the pituitary drive their action, and then also what the final products do. So we're going to be creating testosterone in this physiologic feedback loop, but testosterone is going to be modified then into things like estradiol and DHT, which have different actions in the body than free T or free testosterone. So we'll start out with spermatogenesis, or the creation of sperm, and that is a process that involves both mitosis and meiosis, because eventually we're going to have to split the DNA in half so that it can combine with the DNA from a cell, from an egg cell, from a female. And throughout the spermatogenesis process, these cells will mature. They will have to go to different places in the tract to mature and then visit other places on their journey throughout the male reproductive tract. So each of those pieces of the reproductive tract has a different job in creating a mature semen to deliver sperm. And then to tie up the final physiology, we'll talk about the erectile response, which is necessary in order for spermatogenesis to be created and finish. So spermatogenesis creates sperm, but that sperm eventually needs to go through an emission process. So it has to be removed from where it's stored. And in order for that to happen, there has to be an erectile response and then a final orgasm response so that the sperm can be delivered. There's different chemicals that are involved. Some of them are going to be independent and local things. So those include things like nitric oxide, which is a protective mechanism. And then to fully tie everything together, we'll talk about how medications treat erectile dysfunction, which should complete the story and make everything hopefully make sense. So this is just our introductory slide showing some general pieces of anatomy. So really quickly, I'm just going to talk about some pieces that are very important. So first of all, at the end of the first introductory portion, we'll then go into the reproductive tract. So when we're talking about the reproductive tract, that begins again in the testes area. And some places that we'll have to know are the epididymis, which is where sperm will go to mature. And then when the epididymis contracts, because it's coated on the inside in smooth muscle, the sperm at this point, which is really just sperm and some extracellular fluid, will be delivered then to the ductus deferens, also called the vas deferens. And so that is going to take, detour, a little bit of a trip all the way around the lower abdomen in males. And the first piece of anatomy that's going to add to the semen will be the seminal vesicle. You see it here. That produces a large amount of secretions to be incorporated into the semen. And then once the sperm then has picked up that fluid, it's going to pick up additional fluid from the prostate. And the prostate's going to have not only the function of adding secretions to the seminal fluid, but it's also important in the activation of testosterone, which it converts into a product called DHT, dihydrotestosterone. And then finally, the sperm now will go around, and it's not labeled on here, but there are some additional glands called the Cowper's glands, Cowper's, And those will add the final constituents of the mature mucus to help make it alkaline and allow sperm to survive in an acidic uterine environment or vaginal tract. And then once it's picked up all of those secretions, it will be eventually emitted out through the ejaculatory duct. So this is one long lumen that is going to go throughout the lower abdomen. Okay, so then as we talk about the erectile response, we'll talk about the spongy tissues, the corpus cavernosum, which is on the top portion of the penis, and the corpus spongiosum, which is the larger spongy tissue. And in flaccid states, blood flow to these spongy tissues is minimal, like in this picture. But during the erectile states, the vasodilatory properties of this local muscle response will allow increased blood flow so that there can be an erection. Some other things of note, unlike the female body, the urethra is contingent with the erectile or the ejaculatory duct. So the same duct or same lumen is used for both urination and for emission of sperm. That can be helpful in that the fluid through urination helps clear out the lumen so that there are no leftover products, and it helps clear and clean the tract. One thing of note pathologically is just the prostate. When we look in pathology at the prostatic urethra, in this picture it looks as though there's almost a lumen going through here, so it's like a full tube starting at the neck of the bladder. And that's actually not true. If you look at the prostate at a cross-section, it looks like a donut. So the prostatic urethra is just a hole through the inside of the prostate. And that sits right below the urinary bladder. And as you might know, as part of normal aging, when DHT production goes up, it's normal for the prostate to enlarge. Because of that relationship to the bladder, you'll see the enlargement cause the prostatic urethra to become very small in size, which means that there can be urinary stasis, urinary infections, so bladder infections. And the rule with urine is that it's sterile as long as it's moving. So that's something that we talk about more in pathology, but we'll link together the physiology of why that occurs in this lecture. Okay. So here we see again the sagittal section showing the multiple pieces that we'll have to know. One thing we didn't have prior is the Cowper's gland or bulbourethral gland highlighted. So that's the final piece of the puzzle that will add the final secretions for mature semen. And now we're starting to look at close-ups of the testes within the scrotum to see what the actual anatomy is. Just for a little note, these are all simplified pictures, so even though it looks like there's 6 or 7 lobules separated by septa in these pictures, in reality it's hundreds of these in each testis. One thing that's also important in pathology and for real life, there is not a lot of things that anchor the testes to the wall. That is important to remember because there's a venous area and an artery, the testicular artery, which supply the testes with their blood flow. In the case of a testy twisting, that's called a torsion, if that's not corrected almost immediately, there's not much time actually to untwist it and restore blood flow, that leads to something called a hemorrhagic or a red infarct, which can be very, very devastating. And that is something that happens. It's very common in things like contact sports, where this can just twist because there's not a lot anchoring it to the body. And we'll see that too in females with regards to the ovaries. There's not a lot of anchoring tissue along them. So the things that we're going to start with are these pieces inside of the testes, and I mentioned this in class, but whenever there's an S in the male physiology, it usually is referring to sperm. So we'll be talking about the seminiferous tubules, where spermatogenesis occurs, and then we'll talk about other related cells in that area helping to make testosterone. And then we'll end with this journey of mature sperm from these seminiferous tubule areas up through an area called the rete testes, which is actually a specialized not really sarco, but it's a specialized smooth endoplasmic reticulum, so SCR. And if we think about endoplasmic reticuli back in the cellular chapter, you might remember that the smooth ones are associated with things like detoxification or other specialized types of functions. So the reach testes is where everything kind of dumps into before it gets to the epididymis, which has 3 parts. So these hormones are created within the testes, and they help primarily. The main function is support spermatogenesis, or the creation of sperm. Also, the hormones will help maintain the reproductive tract that we followed throughout the body, and then the semen, making sure it's the correct pH and consistency so that the sperm can be delivered. Also, these things, especially like testosterone and DHT, maintain the secondary sexual characteristics like anabolism, hair growth, laryngeal voice deepening, and also the sex drive, which is required in order for there to be an erectile response and then delivery of the semen. So we'll start out with the main reproductive organs of the male physiology, and that is the testes. So again, there's typically 2 testes in the male anatomy. There's a left and there's a right. They have a little bit of a difference in the way that they hang. One is a little bit lower than the other, and that's just to allow more free movement of them within the scrotal sac. The scrotal sac is a free-hanging structure from the body cavity, which allows the testes to sit at about 2 degrees below core temperature. And you may have learned in anatomy and other courses that there's a group of muscles. There's the cremaster muscles, which help bring the testes closer to the core of the body cavity. In the case where the testes become cold, there are another set of muscles which help descend the testes when they become overheated. It is absolutely crucial for sperm development to have that 2-degree difference from core temperature. If the testes are too warm, then there is inadequate spermatogenesis. That doesn't mean doing things like keeping a laptop on your lap so the battery heats up, or wearing very constrictive pants or underwear is a great way of instituting birth control. But when individuals visit fertility clinics and they're working on making healthier, more motile sperm, those are some interventions that are suggested. So wearing looser fitting clothing, not having anything hot on the lap, not having an oven that's near the level of the scrotum, because if they're not 2 degrees below temperature of the core, spermatogenesis is not adequate. One important thing, though, is that the other cells there that do things like make testosterone, those do not have that temperature requirement. So individuals can have normal T development, but inadequate spermatogenesis in the cases that there's alterations to body temperature. Another reason why that's important is there's something called cryptorchidism in an individual. So if I'm just drawing, like this would be a belly button. In utero, the testes, they kind of derive from the same cells that are going to become the kidneys. So it's important for the testes to migrate down, that looks like a happy face, well, into the scrotum. In the case that they don't, they can actually end up lodged in places like the abdomen, in the inguinal canal, and that should fully fix itself so that they are descended into the scrotum by the time birth occurs. If that's not what happens, there's about a 6-month window where the infant will be monitored to be sure that the testes do descend. If they haven't descended by 6 months, there is a surgery to take the testes from the cavity and then anchor them into the testes. If they're not there, again, there won't be adequate spermatogenesis. However, that's the least of the problems. The more troubling problem is that first of all, cells that make or help in the development of sperm almost are always involved in testicular tumors. That's where we see changes. And if they are not descended and they're somewhere else in the body, the chances of those testicular cells turning into a cancerous growth are very high. So it's really important in life that they fully descend, and it's also important that they descend and be 2 degrees below core so that they have the ability to adequately produce sperm. So looking at the anatomy now of the testes, there are a couple of areas that I want you to pay attention to. Let's use magenta. Okay, so we have the seminiferous tubules. So the seminiferous tubules, those are in these loops. As you can see here, they're looped. And there are about 300 different lobules. And those lobules are divided by septa right here. So just as you would have septa inside of your nose, we all should have that. And it separates our right and left nostril, and it also gives some structure to the nose. In this picture, there's 1, 2, 3, 4, 5, 6, 7 different lobules. So this is just making it simple for you so that you can visualize what these look like. So each of these 300 lobules contain 2 to 4 loops. Like in these pictures, you see 2 loops of seminiferous tubules. And these seminiferous tubules are the places where spermatogenesis occurs. Then the seminiferous tubules empty into the rete testes, so the rete testes right here, again, a specialized smooth endoplasmic reticulum, smooth ER, and that helps with a detoxification process. It helps keep them safe. It's a nice storage area, and it's also a place where we can ensure that the sperm hopefully won't be affected by the blood flow. So just like we have a blood-brain barrier, everybody has one of those, there's also a testicular blood barrier, because we don't want free exchange of everything that's in the body mixing with these immature sperm. Okay, so as sperm is created, it empties into the rete testes, and then it's conveyed through these efferent, which means going away from, efferent ductules, which means little ducts. And these efferent ductules lead to the epididymis. The epididymis is made up of a head, a body, and a tail region. And the inside of the epididymis is coated in smooth muscle so that in an erectile and then eventually an emission response, the smooth muscle contracts and then propels sperm up through this duct system. In this picture, it's labeled the vas deferens. You'll also see it labeled the ductus deferens, which means the duct. Vas deferens is another term that you'll see used. So some important things about the epididymis are that not only is it what contracts so that sperm can be emitted, it's also the place where sperm goes to mature. Before sperm gets to the epididymis, it's immature and it's non-motile. So it has to eventually go through this, or the sperm, which we'll see are just, there's 3 different pieces to them, a mid-piece, a head, and a tail. They're not motile, so they would just go and float rather than swim. Okay, so that's the anatomy. We've got these lobules with the seminiferous tubules in them, emptied into the rete testes through the efferent ductules and then into the epididymis. Just a couple of other things of note. So one good thing in pathology we talk about is this fibrous, inflexible capsule inside of the testes. Why that is a good thing pathologically is because, as we said, almost always tumor growth starts with spermatic tissue. If anything starts growing inside of the testes, there's not enough room in this inflexible capsule to accommodate that growth. So what that means is there's typically some sort of discomfort, but then also there is a physical nodule that can be palpated or felt in the case of testicular cancer. So when it is found, it's not one of these cancers that's very far progressed. If people are doing a self-examination and paying attention to any pain from the testes, it's a cancer that's usually found early, and it has very good outcomes when it is found early. All right, then there is a a layer, there's connective tissue surrounding it, just like all of our other organs we've talked about, like the pleura, and then there's a pericardium. So in testes, it's called the tunica vaginalis. This begins at the outermost layer of this inflexible capsule that we just talked about, the capsule, and it's called the visceral layer, and viscera means inner. So that should help you remember that the visceral layer is the layer that's closest to the inside of the body. Then there is a cavity filled with some fluid, and then the outermost layer is the parietal layer. And these are the words you're going to see really in every single cavity in the body. Visceral is inner, there's a layer of fluid, and then the outermost is the parietal. Again, taken together, this is the tunica vaginalis. There are cases where this can overflow with fluid, so there's a lot of fluid there, which then has to be aspirated. So that is something we talk about again in pathology. So typically there should just be a small amount of fluid. All right, so going into the seminiferous tubules, again, we're doing a close-up of this area right here. So the seminiferous tubules, they are the areas that produce the sperm. And then the straight tubules, these efferent tubules, they convey the sperm to the rete testes. Okay, so the rete testes. And then these efferent ductules will deliver it to the vas deferens, the epididymis, which will, the head, the tail, the body, the tail's down here. And then the emission process is the moving of that sperm all through this now duct region. Here is what I was talking about before. This is the spermatic cord, which helps to, it's small. Can you see that there? It's just a small little area that allows the testes to hang. Again, if this twists, what happens is that you cut off this blood supply, and remember, an infarct is dead tissue. So this tissue will start to die, and then it will start to bleed into that area. So you have to untwist it, and then there's a surgery that's done to anchor the testes to the wall so that it doesn't twist again. And then while they're in there, because there was one that twisted, there's a good chance that the other one might twist. So they'll anchor both testes at the same time. So seminiferous tubules, again, S, seminiferous. So those are the ones associated with sperm. Okay, what we're looking at here is the histology of the testicles. As we said, there's not just 3 lobules or 7 lobules, there's hundreds of them. So the tubules make 2 compartments within each lobule. So we have the intratubular compartment. Whoops, what happened? Intratubular compartment and the peri, or around the tubular compartment. So in the tube, around the tube. Intratubular is referring to the seminiferous epithelium. So the seminiferous tubes, the epithelial cells that make up that area. Peritubular compartment, so those are the areas around the tubules. Those contain connective tissue, which is common, immune cells, so that anything that gets in here that's pathogenic can hopefully be destroyed before it has the chance to mess up the sperm. And then also the cells that make testosterone, the Leydig cells, lie within the peritubular compartment. All right, so we have intratubular compartment, and then we have the peritubular around the tube compartment. So this is just a cross-section showing you what these seminiferous tubules look like. Okay, so we'll just briefly go over spermatogenesis, the creation of sperm. It's a process that takes about 72 days. You've got this all written out for you here, but I'm going to, so that you can read it, not but you can read that. This is going through this process. So again, we're going to have mitosis, which is the splitting of 2 cells into identical daughter cells. Meiosis is when you take a cell and you split its genetic information into a haploid so that we only have half of the genetic material. Okay, so everything in the body begins with stem cells. So here we're going to talk about primordial in females too. You might have heard the name primordial soup when you talk about the way that life was created on the planet. The primordial soup refers to the absolutely correct amount of ions and minerals and oxygen that scientists hypothesize would be necessary for life to be created. So primordial, that means the earliest you can get. So the primordial germ cell. So this is the earliest you can go. This is the stem cell. So these like primordial cells, these are sitting there essentially in the body. You have them all over, and they can differentiate into whatever tissue type they're associated with. So these primordial germ cells, so that means that it has the ability to turn into any of the 3 germ layers that you've learned in your various classes. And once this primordial germ cell enters the testes, it's now committed to being a testicular type cell. So this first sperm-related, testy-related cell is called a spermatogonia. And spermatogonia, they're just testicular adult stem cells, which means it's a tissue cell. It's an adult stem cell. It can't become a brain cell. It can't become a bone cell, but it can become all kinds of sperm and testy-related cells. So when you're at the level of stem cells can divide, and they divide mitotically, meaning that they split, they make copies of themselves, and it turns into 2 identical daughter cells. Okay, so one or more of these typically is going to just chill out as a stem cell. That's one thing that's fun about stem cells. So see how this is just going to chill out here. Stem cells have the power of self-differentiation, which means if they don't get a growth factor, or if they have the capability to do it, they can split into another copy of themselves. Once you're past the original stem cell, those subsequent cells don't have that ability. Once a stem cell goes forward, it lacks self-differentiation. So stem cells can stay stem cells. So that means one or more of these spermatogonia can chill as a stem cell so that it can start this process over again if it wants to. The other ones are going to have to, instead of doing mitotic division, now that we have a more mature cell, they are going to have to drop both sets of genes. So the chromosomes in here are enough for one person because they're the stem cells from one person. Now in meiosis, we are going to have to split that, okay? Meiotic division. And there's 2 meiotic divisions, 1 and 2, between the primary spermatocyte. 1 meiotic division gives you a secondary spermatocyte, and then the second meiotic division gives you the immature sperm called a spermatid. So a spermatid is the cell type which has 1/2, it's haploid. It has haploid, or 1/2 the amount of chromosomes, so that it can combine with the 1/2 of chromosomes from a female egg to make an organism. If like in different thought experiments in science, we say, well, what would happen if meiosis didn't occur and now you have the full set of chromosomes which then merge with, a haploid egg cell? Well, that would mean you would have enough chromosomes for 1.5 people, and that egg wouldn't fertilize. That's called incompatible with life. So this is something that happens. If it doesn't happen correctly, then it's not going to end up making an embryo. All right, at the very end of this process, there's a mature sperm. So then that mature sperm is going to hang out for a little bit. It's going to be stored until it can become motile. So this is a long process to go from stem cell to mature sperms. This entire process from the primordial cell to the final mature sperm. This is just like showing you like how long it takes for each one. 25 days here, 9 days here, 19 days here, 21. So this is a nice long process. This takes quite a bit of time. And that is possible because males do not have a set cycle. Females have a set cycle of the menstrual cycle, so 72 days is way too long. That would mean women would menstruate every, 3 months or so. 2 months or so. Yeah, 3, 2, 3, whatever. Okay, so then we'll talk about the mature sperm, the spermatozoon. And in the mature sperm, the nucleus is really tiny because its job is just to swim. It has a tail and a body. The cytoplasm, there's not a ton of it, but it does have a specialized type of lysosome which helps it penetrate into an egg. And that area is called an acrosome. So here's this process. We started with a spermatocyte, and then it becomes an immature spermatid. It kind of looks like a tadpole at this time. And then the mature sperm has an end piece, so like the final piece of the tail, a principal piece, which is considered another piece of the tail, so that these tail pieces are considered one piece. And then the mid piece, that's the area with things like mitochondria, because this has a flagellum. And in order for flagellum to flick so that it can swim, there needs to be ATP. There's a lot of mitochondria here generating ATP so that this can be a swimming cell. This is the nucleus, and then the nucleus, like a helmet, is surrounded by the acrosome. And if you remember that the lysosome is the stomach of the cell, then you will hopefully know that acrosome, just like lysosome, has highly acidic contents to digest things. So here's the deal. A sperm cannot get into an egg without acrosome. I'll also dispel for you in a little bit the myth that whatever the first sperm is to get to the egg is what fertilizes it. That's not it. It's actually the most opportunistic sperm, and we'll see why that is in a little. Okay, so here's another picture of a mature sperm. Here it is, again, like I said, one tail piece. There's an end piece, a chief piece. There's a microtubular structure. This is what it looks like from above. There's lots of mitochondria. In the principal piece, there's a neck portion, a body portion, then we're up to the head portion. And we've got the nucleus, where there's a vacuole there, there's a surface membrane, and very importantly, there's an acrosome. So the acrosome, which contains really acidic things, enzymes, is going to be separated from the rest of the sperm so that it is not degraded. Okay. So some more histology of the seminiferous tubules. So here we're looking at really one. So before we were looking at a bunch of different ones. So here are a couple. The M is for myoid cells. S1 is showing you these primary spermatocytes. So these ones look pretty big. We can tell that they're immature because they have nice, large, darkly stained nuclei. And we've learned that as sperm become more mature, their nuclei start to get smaller. S3, these are the spermatids here. So now these are the, like the tadpole ones I just mentioned before. And then the mature spermatid, or what we call the spermatozoon, those are labeled SB and SA. So this is a process where we're going to have things migrating around the seminiferous tubules until they finally mature. And the cells that help with that are called the Sertoli cells. So they look a little bit different. They have a nice normal nucleus. The Sertoli cells are also called nurse cells in that they nurse, or they act as a nurse to guide the spermatocytes, so like the individual like stem cells, through the process of becoming mature. So they help with that process. They nurse them along the way. So they don't themselves make them because these are derived from stem cells, but they help them along that way. They help form gap junctions between these different cells so they can share nutrients really easily. And without the Sertoli cells, then there's no sperm production. So here again is a picture of these Sertoli cells. So we saw them in real life just back here. So we're here, Sertoli cells. This is what one looks like in real life, helping to nurse these spermatids along. All right, So some things I want you to take notice of. Let's do red here. So as we said, these Sertoli cells, they surround and help nurse the sperm cells. So they're here in purple. So here's a Sertoli cell. Here's a Sertoli cell. They look like nice octopi, or in The Simpsons, those green aliens or yellow aliens that always come and run in the elections and do things. They look similar to them. They have lots of processes so that they can help connect one another and help each other out to take care of their little baby sperm eggs and help them grow together. And as we see, we have these cells maturing in this outward type fashion. So we've got their spermatogonium, then they move to the next level where they become more mature. We have the first meiotic division around this time. Then we have secondary spermatocytes once it moves to another layer. Then there's their spermatids. Those are the step before the mature sperm, so the immature ones with the haploid gametes there. And then the final, here's some spermatozoa. So as sperm mature, they are going to move from this basal layer and move further and further down this way. So it's like going through a check line as they mature. So Sertoli cells, they surround these cells and they form gap junctions with all stages so that there's a free exchange of nutrients to the cells. And then it's their job to also traffic the cells so that they're moving in the right direction. So they're the ones taking care of this process. In order for spermiation or the liberation of the sperm to occur, these gap junctions have to be broken down. So you can see here, there's lots of gap junctions. And then down here, these are now broken down so that the cells can move out. Again, once this process happens, they're non-motile and they have to mature in the epididymis for about a day in order for them to become motile and have a swimming flagellum. The other thing I mentioned is that there is a blood-testes barrier. This helps prevent the blood from the periphery entering this area of the testes and then having carcinogenic materials, for example, mix with this genetic information. That doesn't mean that it works all the time. You may have heard about different things that affect the creation of sperm, like dietary things, smoking, radiation. There's a lot of things that can affect that, but at least this blood-testes barrier does its best to try to prevent really large damaging objects from getting in. Okay. Other things about the seminiferous tubule. So we've mentioned that Sertoli cells, again and again and again, they have an S in them, Sertoli cells. So that means they need sperm. And as we'll put together with the HPG axis, there's the hypothalamus making a releasing hormone, right? So in this case, it's gonadotropin releasing hormone, GnRH, which will signal to the pituitary, and the pituitary will make two products, FSH, follicle stimulating hormone, and LH, or luteinizing hormone. And those are named for what they do in the female body. FSH drives the follicles or the eggs to mature, and luteinizing hormone drives ovulation. To luteinize means to yellow. When the egg ejects itself, there's yellow tissue left over. It's called the corpus luteum. So it's named for that, but it still is going to be present in the male body, but obviously have different jobs. So again, if there's an S in it, I want you to remember that has to do with sperm. So FSH binds to Sertoli cells, which we know make or help at least nurse the sperm along. So FSH sperm. So here's a Sertoli cell, and here is FSH binding to its receptor. Remember, this is now a steroidogenic cell. FSH is not a steroid hormone, but we're going to activate the creation, here's a cholesterol backbone, of different hormones, which will help to mature sperm. Okay, so FSH is going to be required for Sertoli cell activity. Look at this nice picture. You see the immature sperms over here and then the mature ones with their little flagellum hanging out on the outside. Isn't that nice? LH binds to Leydig cells, which starts with an L, so hopefully that's easy to remember. And what Leydig cells do is make testosterone. Testosterone. So S is sperm, LH, Leydig cells. Here's a Leydig cell, so LH binds to its receptor on Leydig cells so that there is the creation of hormones like testosterone. So one important thing to keep in mind, not only do you need FSH for sperm production or spermiation, there also needs to be Leydig cells making testosterone. Without testosterone, there cannot be adequate spermiation. So by itself, it weakly stimulates spermatogenesis, but in conjunction with FSH, testosterone, follicle stimulating hormone, are both necessary for a nice mature sperm. Okay. So that's what that was alluding to. Something else is needed to stimulate it. Well, you already know the answer. It is testosterone. And testosterone comes from Leydig cells. The L in here is for Leydig. So Leydig cells are here. Here's a Leydig cell. How pretty. Here's its nucleus. Here's another Leydig cell. And then you have capillaries. And remember, so here L is for Leydig. Okay. All right. Capillaries are important because they carry blood. Remember, hormones are carried in the bloodstream. So as Leydig cells produce testosterone, it can enter the bloodstream and then be carried off into the body. Okay, Leydig cells, they are steroidogenic stromal cells, and stromal means like the stroma of a tissue is like the functional part, but also a supportive part. They're steroidogenic, which means they can create steroids. And the way that we create steroids is by using cholesterol. There's two types of cholesterol. Well, there's more, but let's be simple today. LDL, HDL. LDL is what people call the bad cholesterol. L is for lame, so that'll help you remember that. So LDL receptors, here's an HDL receptor. And then we have the creation of like free cholesterol. So one little thing for histology reasons you should know, and then we talk about this in pathology too. Whenever there is the breakdown of cholesterol into cholesterol esters, that's what CE is, there's usually a little droplet left over, like a little free droplet. Why that's important, a little important for histology and definitely important for pathology, is you can tell when you're looking at steroidogenic cells because they appear foamy or bubbly. And the reason why is that little leftover droplet. So cells that use cholesterol, they appear foamy or bubbly. All right, so free cholesterol, free cholesterol. You'll see this word all over. Once we get our free cholesterol modified into the first step, which can then become anything steroid hormone related, there's pregnenolone. And pregnenolone turns into progesterone through different enzymatic processes, and then progesterone can turn into whatever we want. In this case, it would be testosterone. So Leydig cells utilize cholesterol. They have receptors for cholesterol on them so that it can be brought into the cell. This is through receptor-mediated endocytosis. So once these receptors are full with cholesterol, then this forms an invagination, and then there's actin and myosin here, and it'll snap it shut to contain it in a vesicle. This looks like a weird frog face. Let me draw a little frog nose. Yay. All right. So then it's in a vesicle, and then it'll be modified into a free cholesterol ester. How does it get there? Probably carrier proteins. That's a good guess. I like when I see question marks in books. That makes me happy. Okay. So now we have cholesterol taken in, we have the precursor of pregnenolone, and then eventually the creation of our final steroid hormone, testosterone. So this is that pathway that I just mentioned. Pregnenolone is the precursor from the cholesterol backbone, and that becomes then progesterone, different forms of progesterone, androstenedione, and then we've got our cholesterol. So cholesterol, I'm getting hungry. I'm thinking about cholesterol. Testosterone can either enter the blood as just free T. ABP refers to albumin binding protein. Albumin is the most prevalent protein or globular protein in the bloodstream. It's kind of like a boat for drugs and for hormones. And the longer something is bound to albumin, the longer it has action in the body. So some of it can just enter the body as free testosterone, hitching a ride on its little Uber called albumin. The remainder will go a variety of places. So some of it will go to the adipose tissue, where it will be modified into the main circulating form of estrogen in males and females, estradiol 17 beta. In other places, like the prostate, I shouldn't have said places, there's only one. In the prostate, when testosterone gets there, the prostate converts it into DHT. And DHT has actions in the genitals, skin, and also prostate. Why is that important? So it drives things like libido. That's why genital is there. So it helps encourage erectile response, sexual response. Skin refers to like skin changes that occur with age. Males and females have different skin. Some is rougher, some is softer, some has more hair, some has less hair. Also, the more DHT there is, you could tell that somebody has high DHT by a lot of ways, but a simple way is to look at the hair on their head. The bigger the prostate, the more DHT there is. The more DHT, the less hair on the head, and then the more hair on the rest of the body. And then why prostate is in there is that the more DHT there is, the bigger the prostate. So when people are treated for an enlarged prostate, they take drugs that block DHT. If you block DHT, the prostate doesn't grow as big. So it does a lot of secondary sexual characteristics, but also encourages prostatic growth. Okay, so I'm just going to go forward to get rid of my writing. Okay, when there is conversion of estradiol in the adipose tissue, in males, there's a similar activity of estrogen with bone strength. So you might know that when women go through menopause, they lose a lot of their bone density. And that's because estrogen is protective on the cells called osteoblasts. Do you remember learning about those? Osteoblast. There's osteoblast and osteoclast. B is for build. Osteoblasts build bone. And as long as there's estrogen around, then osteoblasts stay alive longer, which means that bones are nice and strong. When women go through menopause, estrogen rates go way, way down, which means the fracture rate goes way, way up. So estrogen is really important for bone strength. When males do not have an adequate conversion of testosterone into adipose tissue, into estrogen, into estradiol, that could be because of low adipose tissue levels or due to a genetic or congenital abnormality. They become very tall, so very tall stature, and they have a high risk of fracture. So that can be reversed by giving hormone replacement therapy. It's typically not seen because it's really early on and you think kids are just tall. So if they're not getting regular hormonal screens, it would be easy to miss until they're older. And because they're so tall and they have such long limbs, they're really fast or good at a sport. And then you're seeing they're getting repeated stress fractures. And by that time, it's kind of difficult to reverse it because once you're 18, your skeleton just starts getting weaker after that. As we mentioned, DHT is important with pubertal effects, so puberty, genitals, skin, and then also later on as the DHT becomes more predominant, it's also really important in skin changes, hair changes, and then prostate hypertrophy. Testosterone drives testicular cancer, so just know that. So whenever you're giving people lots of testosterone, just keep in mind that a large portion of that will be converted into DHT. So the more testosterone there is, the more likelihood there is of cancer, specifically prostate cancer. In females, breast cancer and endometrial cancer is estrogen dependent. The more you have of that, the more likelihood of cancer. So testosterone is tied directly to prostate cancer. So here is a graph or a picture showing you all of the effects of the various hormones we just mentioned. So these are our anabolic types of effects. So we see the effects of testosterone, either just free T, like you see down here. Free T increases the precursor to LDL, so increases very low density lipoproteins, which are turned into LDLs. That conversion process is done by an enzyme called HMG, CoA reductase. That's the way cholesterol drugs work, those statin drugs. They prevent the conversion of VLDLs into LDLs. And our healthy cholesterol, HDL, we call it healthy because it's a trafficking protein and it brings LDL to the places that can use it, like the testes or the liver. So free T drives high cholesterol, but it also encourages red blood cells to differentiate. It encourages protein deposition, abdominal visceral fat, so inner fat, not external fat. So it does create more of that, especially with age. Estrogen, we know, is important with the skeleton. Free T drives the voice to become lower. Free T, also together with estrogen and DHT, sex behavior, libido, sex drive. Also, DHT, T, and estrogen affects the HPG axis so that we can have shutoffs. Testosterone also affects activity of everything in the tract. DHT, as I mentioned, helps with, first off, during puberty, lengthening of the penis to an adult length, and scrotal activity, urethral function, prostatic function, and then also drives that as things get older. And then these other things, skin and hair related, so beard growth, more sebum. When people go through puberty, testosterone levels spike. So there's a lot of DHT, which drives more oil production. At the same time, the pores get larger. So that's why you see acne primarily in teenagers. We already talked about prostate growth, and then DHT, puberty, and also seminal vesicle activity. So depending on what it's made into, testosterone has so many actions. Keep in mind that even though it's the same hormone, and even the converted hormone, depending on where the receptors are, its activity in that tissue will be much, much different. You may have seen androgel commercials or seen it in stores. What androgel is testosterone gel. And people take this for a variety of reasons, all of which would be to address issues with everything on the slide prior. So maybe sex drive issues, maybe hair issues, maybe they want more protein deposition. Just keep in mind, so this is a gel and it is put on the body. It's not supposed to be put on the genitals because that causes, that's a very bad side effect of too much testosterone near the testes, which can cause a lot of growth of seminiferous tissue, which we know is more likely to be cancerous. But these things work, and when people are deficient in testosterone, absolutely you can supplement the hormone. That we call that hormone replacement therapy. But when people are not deficient in a hormone and you're giving a lot of testosterone, not only will you have the feedback loop causing testicular atrophy, because now they're not busy anymore and there's a feedback to the brain that there's plenty of testosterone, so then there's low or LH, and then low LH means low testy activity, Leydig cell activity. So you'll have testicular atrophy if it's a really large dose, but also keep in mind the really troubling effect is that the side effect of too much testosterone is prostatic cancer. So if you take a look at the enclosed medication guide, see accompanying insert, the side effect for this, as you shouldn't be surprised to learn, is prostate cancer. So if you hear about one of your patients taking an androgen type gel, just warn them that that's the side effect. As we've mentioned, testosterone enters the circulation either free, a bunch of it is bind to albumin, that's the most prevalent protein in the bloodstream for everybody. There's also a specific sex hormone binding globulin, AHBG, which a huge amount of testosterone circulates to, so it can bump off more easily. Testosterone is eventually excreted through the urine, 30% from the testes. The rest, or 30%, is going to be from the testes that's excreted. The rest is adrenal when it's excreted. And the way that it's fully removed from the body is through a second order metabolism process where things are added to a substance to make it water soluble so that it can be excreted through the urine. That means either a sulfate or a sulfation reaction occurs or a glucuronidation reaction occurs. The good thing about glucuranates is that these are the earliest enzymes to appear in the body, and they're also the ones that are around the longest, which means when you give drugs or hormones that are removed via glucuronidation, they can be used in kids and in elderly individuals. Okay, so here's your HPG axis. As we've mentioned before, I really want you to know your feedback loops. Hypothalamus, GnRH. We know if it's an RH, a releasing hormone, it is going to come from the hypothalamus, releasing hormone. We also know trophic hormones come from the anterior or adenohypophysis. Okay, so in response to gonadotropin releasing hormone, the anterior pituitary will start to spit out its products, follicle-stimulating hormone and luteinizing hormone. LH binds to Leydig cells, which make testosterone, which travels through the bloodstream to signal to the hypothalamus and pituitary that testosterone is adequate. So when that occurs, you'll have the production of gonadotropin release inhibiting hormone to antagonize receptors on the anterior pituitary so that there's no more production of LH. Interestingly, so this system is both endocrine, so obviously testosterone is endocrine. Sperm, well, they're not, right? They are a thing. So they can't just swim through the bloodstream up to the hypothalamus and then shut off production of more sperm. They're exocrine. They go through a duct and then they exit the body. Okay? So when there is high Sertoli cell activity, so if we look over here from your book, so here we have FSH, or sperm follicle stimulating a Sertoli cell, and then we have spermatogenesis. The more active a Sertoli cell is, the more of a product is created called inhibin. So inhibin with FSH is going to be the feedback. So when there is too much Sertoli or adequate Sertoli cell activity, that will help shut off more production of FSH. As we said, LH, testosterone can do its own things and have its own effects. We also said that testosterone is also needed to turn Sertoli cells on. So the negative feedback in this pathway is testosterone for LH and inhibin for FSH and the Sertoli cells. Okay. All right, Leydig function, we already went through this. LH receptors, they catalyze the reaction of hydrolysis of cholesterol esters. You get more steroidogenesis. That feeds back to the hypothalamus and pituitary. So it can either block GnRH or inhibit it by making GnRIH. This is what I just said before. Sperm can't swim up to the hypothalamus and then shut off anything, so inhibin shuts off the level of the pituitary so that there's no more FSH. Okay, very quickly, as I mentioned, when people take a lot of exogenous testosterone, one thing that's very, very commonly seen and very well documented is testicular atrophy. So when people inject anabolic steroids, which are a high dose of androgen, again, if we're thinking about the negative feedback, that high amount of testosterone will tell the brain, like, nope, everything is fine. We've got plenty of testosterone. Don't need to make any more. So there'll be low LH. And that means if there's no LH, the Leydig cells, they need less receptors. So they're going to get smaller and smaller. And then you have general testicular atrophy. So we noticed that not only was there testicular atrophy, but there was also low sperm production in people who take a high dose of testosterone. So scientists are like, oh, that's interesting. Maybe we can make money off of that. And so they investigated it, and it's called the loophole. And what the loophole says is that the intratesticular, so levels of testosterone inside the testes, which should be high if those Leydig cells are active, they need to be 100 times greater than the T that's in your blood in order for adequate spermatogenesis to happen. So you need to have really, really high T in the actual Sertoli cells. Does that make sense? Okay. So it should be really, really high, like 100-fold difference in the actual testes than it should be everywhere else. However, if there was a high amount of T out in the bloodstream, the testes themselves, as we saw, they would have no LH receptors, and then they themselves wouldn't be making any testosterone. So low T. So what we see is that because there is not this maintenance, so you need the T in the actual testicular cells to bind to their Sertoli cells to stimulate them. If the Leydig cells are not active and making their own personal testosterone, then there's not going to be adequate sperm, so low sperm. So the first cases of male birth control, which turned out not to be super helpful because, as we just learned, high T equals prostate cancer. But that was the first thinking about making a male birth control is let's take advantage of what we know about having high testosterone in the periphery, but low testosterone in the testes. And that is something we found because of anabolic steroids and associated sterility. Okay, to finish this up, let's just go through the reproductive tract if you don't know it already. So here are the pieces we keep talking about. The one long lumen used for urination and for ejaculation. So let's follow the spermatic journey. As we know, the spermatogenesis journey first begins in the rete testes. So the Sertoli cells will help nurse these immature egg cells through these tubes, eventually into the rete testes, and then it will be conveyed to the epididymis. When there is an erectile response and then an orgasm, that causes the epididymis to contract, and that will propel the sperm up into the urethra, and that's called emission. So it's physically leaving the testes. Just a little note, medicine-wise, you've probably heard of a vasectomy. Ectomy means to cut out or to cut apart. So in a vasectomy, I just want you to notice how close the vas deferens is here to the outside of the body. So the penis shaft is lifted up and then there's an incision made here. It's a very small incision. And then the physician takes about, like a centimeter of vas deferens or ductus deferens tissue out. And the reason it has to be a centimeter or greater is if you cut less, then that tissue can actually regenerate and you make that lumen all over again. But that's why you have to go back for testing to make sure there's no sperm in the ejaculate. And then there's 2 stitches put in, and that's it. and it's over. And typically these are done on Fridays, and then you're back to work on a Monday. So it's a very, very easy, very quick, about 15-minute procedure. And in that procedure, instead of the sperm being incorporated now into the ejaculate, remember there's all these inguinal lymph nodes down here. Those would just drain off into the inguinal lymph nodes so that the sperm wouldn't be incorporated into the semen. So just my little note about that. So anyways, if there is no vasectomy, then the testes deliver the sperm to the epididymis, and then it contracts and then moves into the ductus deferens, or the vas deferens, which then propels it all the way around the abdomen. The first places it's going to pick up secretions are the seminal vesicles and then the prostate. Seminal vesicles are named seminal for semen because they make the most of the secretions, and then the prostate adds about 30% extra. So when people do have radical prostatectomies and prostate cancer, they do have issues with libido because we need DHT for libido, but there also will be difficulties in some cases with ejaculation because of the lack of secretions. And then the final place secretions are picked up from is the bulbourethral, or the eponym Cowper's gland. Eponymous means named after a person, is what adds the final little 10%, which is mostly mucus. And that mucus is thick, it's alkaline, and it contains an enzyme called coagulase. So like coagulate, you know that word. Coagulate means to like thicken or harden. So coagulase is an enzyme that forces coagulation of semen. Okay, and then it's expelled through the urethra, one long continuous lumen. So other things that happen there, we already know that sperm matures, and it takes about 72 days to get a mature sperm, and it has to pass through the epididymis to mature, and it can chill out there for about 30 days without any lack of viability. It can also be stored in the tail or vas deferens without any lack of viability also. There's a lot of sympathetic input in the vas deferens. When we teach anatomy and physiology in younger classes, we use a point and shoot thing to remember ejaculation and erection, where the point means erection and the S means ejaculation, so point and shoot. So in order for there to be semen delivered in ejaculation, that S is for sympathetic. So that's to help you remember parasympathetic and sympathetic. So ejaculation is sympathetic related. Sympathetic. And sympathetic stimulation is started by tactile stimulation, which means touch. So that turns on those nerves that go converge with the penile anatomy. Then there's peristaltic contractions, which empties the vas deferens and the prostatic urethra. There's emission. So sperm and seminal contents, the production of those things is the most important thing, just physiologically as a species, that the tract would do. And then the erection ejaculation response, so that point and shoot, that's parasympathetic. That's S2, 3, 4, S through 4. Those nerves and the pudendal nerve are going to help out with the initial erectile response. Okay, so here is your autonomic nervous system input. So sympathetically, it's the lowest you can go, because we know it's T1 to L2. So T11, 12, and then L1 and L2, they stop at the sympathetic chain, and then they're going to take a little stop at the superior hypogastric plexus, converge together with the pelvic plexus, and go activate the ejaculatory response. Whereas the parasympathetic system is S2, 3, 4. We've got the pelvic nerves down here, so that converges with the same pelvic plexus that the sympathetic did. And then we have the pudendal nerve coming down here, and these different pelvic nerves, cavernous nerves, to help with the erectile response. And I'll talk you through just very quickly to end how this erectile response happens, but it's going to involve a couple of different things that you'll have to know. So the first one is nitric oxide. The second one is going to be this enzyme, PDE5, phosphodiesterase 5. In order for there to be an adequate erectile response, the smooth muscle and these spongy tissues, they have to relax. If they can't relax, then there's a difficulty with erection. So here's the penile anatomy. There are two corpus cavernosum. So as I said early on, these are on the anterior dorsal part of the penile anatomy. And then there's the corpus spongiosum, which is this general spongy tissue more on the bottom part. The corpus cavernosum urethra is the specific spongy tissue that runs through the corpus spongiosum. So the corpus spongiosum is really big, and then the urethra cavernosum runs through that. Corpus means body, so corpus, like cavernosum, that means cavern-like bodies, and then spongy bodies. So in flaccid states, again, these spongy tissues have almost no blood flow. So there has to be changes to the amount of blood flow for this to occur. Okay, so first off, we have a flaccid state with minimal blood flow to these spongy areas. And in this picture, there's an erectile state. And now we see that these halcine arteries, which typically would not be filled with blood, they're allowed to vasodilate, and then the area can engorge with blood. So that's the key, is minimal blood flow to the spongy tissues. The halcine arteries are constricted when there is an increase in blood flow. So an increase in blood flow happens to the genitals when there is somatic sensations, tactile sensations. It can even be thinking of something. It doesn't matter. It can be sensory. It can be tactile. But the first thing that happens in the case of somebody going through an erectile response is an increase in blood flow to that area. Does anyone remember what the force of blood flowing against arteries is? Anybody? Anybody? So blood flow goes up, the force of it, whoops, that is called the shear. Does that sound familiar now? The shear. Why is it called the shear? I don't know, but that's what they call it. So shear stress refers to the force of blood flowing through a vessel. When shear stress goes up, it's more likely that vessels become damaged. When vessels become damaged, they form clots. They can be thinned into aneurysms. So there's a local protective mechanism that happens all over the body, and it starts with the muscle cells. So this is just one vascular smooth muscle cell. So the smooth muscle cells that line arteries, and in this case, the halcine arteries. When there is an increase in blood flow, so sexual stimulation, you get an increase in blood flow. What happens is that this local smooth muscle cell acts on nitric oxide, which is a gas and diffuses really easily. It comes from these cavernous nerves. Nitric oxide is modified from cyclic GMP into GMP. And that GMP is not full of energy. It's not going to catalyze a reaction. So that allows nice relaxation. So when these vessels are relaxed instead of constricted, that means that they can widen, they can relax, and they can fill with blood. As you saw in the picture previously, so here we had nitric oxide coming from that nerve, and then we have cyclic GMP, smooth muscle relaxation. So anyways, PDE5 is an enzyme that helps make GMP, okay? And then GMP eventually will go back to GTP, which is full of energy. So as I mentioned, GMP, that's not helpful. GTP, that's like ATP. It's full of energy. ATP will turn into cyclic GMP, which is full of energy. So this process can keep going as long as there's nitric oxide. However, this enzyme will start to inactivate this process so that the erection doesn't last forever. So the final piece of this puzzle is that this is going to keep going on. So GTP to cyclic GMP, we get erection. GMP, that's low energy, and that's what phosphodiesterase creates. And then once we have GMP, that will converge back together to start this process over again. So what you see here, there are drugs called PDE5 inhibitors. So those are things like Viagra and Cialis. Not only are those drugs nitrate donors so that there's nitric oxide delivery, but they also inhibit the enzyme that would break down cyclic GMP and allow GMP to converge back together to stop the erection. So again, locally, this nervous signal creating nitric oxide, that's going to lead to this intracellular cascade with cyclic GMP, allowing this nice response to happen so that there is relaxed, dilated vessels and then a resulting erection. And then those spongy spaces can fill with blood. In order to have that keep going, there has to be an inhibition of PDE5, phosphodiesterase 5. And that's what things like Viagra does. So again, here's the endothelial cell, here's nitric oxide, and nitric oxide comes from something called L-arginine. And L-arginine, you might see that, you can buy that in the store. And people buy L-arginine when they do like fitness competitions, because it's a vasodilator, so it makes your vessels pop, which is a cosmetic type of thing, apparently. But it can also be bought in the hopes of treating erectile dysfunction, because L-arginine is modified into nitric oxide, and nitric oxide helps catalyze cyclic GMP, so we get smooth muscle relaxation. However, the reason why L-arginine wouldn't treat erectile dysfunction appropriately is because there's still this enzyme here, phosphodiesterase 5, which will break down cGMP into GMP, and then this will end the erection, we'll start over again. So when you look at drugs like Viagra, Cialis, not only do they donate a nitric oxide, they also inhibit this enzyme that breaks down cyclic GMP, and that allows the erection to continue. What if that doesn't happen? What if the erection doesn't stop? That's really, really dangerous. So it says at the end of the commercials for these, like, contact your doctor if your erection lasts 4 hours or longer. That is a really dangerous complication. When that occurs, it means that the vessels cannot fully relax and then the blood can't flow out. If that is the case, what needs to happen is the individual goes to the hospital and they needle aspirate the blood from the penis out. If you do not do that, the tissue infarcts, and then they have to do a full penis removal. So it's really dangerous. So make sure people pay attention to that. It's not a joke. The erection should not last 4 hours or longer. So that's the way those things work. So hopefully understanding this will make sense when you think about the physiology that occurs in the anatomy of the spongy tissues. Nitric oxide relaxes tissues by creating cyclic GMP. Cyclic GMP goes away when phosphodiesterase 5 stops this process. So drugs interfere with that, and erectile dysfunction is something that leads to a lot of these drugs being sold. Also for clinical reasons, one thing about erectile dysfunction that's clinically significant is that it's a first early sign of atherosclerosis. And scler means hardening. So atherosclerosis means the hardening. Athero means gruel, because you end up with this gross porridge type stuff inside of really large vessels like the aorta. And then osis means development of. So atherosclerosis, the hardening of the arteries. When people have atherosclerosis, in order to have an erection, you have to have blood vessels that can dilate. And hardening of the arteries means that they lose their compliance and their ability to dilate. So when patients report that, that's a really early sign of atherosclerosis. So you can address that by giving medications like this. But you also want to investigate what their vessel health is, and you can hopefully avoid really bad side effects down the road if you pay attention to that. All right, so that's just a little note of that. Again, how this drug works. Just to finish up, in men, there is no distinct thing like in menopause. So andropause, or the stopping of the creation of testosterone, that is not a distinct event. Instead, what you see is a fluctuation of the levels of testosterone and of LH and FSH throughout the lifespan. And it comes into play when, first off, like the fetus is first developing. So if people have ever seen a 20-week sonogram, it's really hard to tell if it's a male or female. There's really not a big difference. It's towards the very, very middle, very end and beginning of the third trimester that it's very easy to see things like the testes. So in these fetal periods, when there's initial development, in neonatal periods, when there is further neonatal development, there are these little spikes. So that's about 1 year. And that will be differentiation, just, voice-wise, hair-wise, things of that nature. And then you'll see that during puberty, the testosterone levels are really going to spike. In adulthood, the levels remain high. They start to dip at about 45. And when you start to see that difference between like sperm production, testosterone production, this age of 45, when you see testosterone dip, DHT becomes more predominant. And that's when you start to see growth of the prostate and also those related changes to what DHT and free T do. And that is it for male physiology. Thank you for listening.